This is a continuation of dysrhythmias. In this video, we will cover part of ventricular dysrhythmias. Ventricular dysrhythmias originate from foci within the ventricles. These may include premature ventricular complexes, ventricular tachycardia, ventricular fibrillation, idioventricular rhythm, and ventricular asystole. First, we will see premature ventricular complex. A premature ventricular complex is an impulse that starts in a ventricle and is conducted through the ventricles before the next normal sinus impulse. PVCs can occur in a healthy people, especially with intake of caffeine, nicotine, or alcohol. PVCs may be caused by cardiac ischemia or infarction, increased workload on the heart, for example, heart failure and tachycardia, digitalis toxicity, hypoxia, acidosis, or electrolyte imbalances, especially hypokalemia. Premature ventricular contractions are extra heartbeats that begin in one of the heart's two lower pumping chambers, that is ventricles. These extra beats disrupt the regular heart rhythm, sometimes causing a sensation of a fluttering or a skip beat in the chest. Premature ventricular contractions are a common type of irregular heartbeat, that is arrhythmia. Premature ventricular contractions are also called premature ventricular complexes, ventricular premature beats, or ventricular extrasystole. Premature ventricular contractions often cause few or no symptoms, but the extra beats can cause unusual sensation in the chest such as fluttering, pounding or jumping, skip beats or missed beats, increased awareness of the heartbeat. Premature ventricular contractions may be caused by certain medications including decongestants and antihistamines, alcohol or drug misuse, stimulants such as caffeine or tobacco, increased levels of adrenaline in the body due to exercise or anxiety. It can be caused because of injury to the heart muscle due to disease. Types of premature ventricular contractions are, first one is bigeminy. That means premature ventricular contractions may occur every other heartbeat. Next is trigeminy. PVC every third heartbeat. Quadrigeminy. PVC every fourth heartbeat. Couplet or pair. Two sequential PVCs can occur. Unifocal, that means uniform upward or downward diffraction arising from the same ectopic focus. Multifocal, it can be in different shapes with the impulse generation from different sides. Next is R on T phenomenon. PVC falls on the T wave of the preceding beat, may precipitate ventricular fibrillation. Characteristics of PVCs. Ventricular and atrial rate depends on the underlying rhythm, for example, sinus rhythm. Ventricular and atrial rhythm is irregular due to early QRS, creating one RR interval that is shorter than the others. The PP interval may be irregular, indicating that the PVC did not depolarize the sinus node. QRS shape and duration. Duration is 0.12 seconds or can be longer. Shape is bizarre and it can be abnormal. P wave. Visibility of the P wave depends on the timing of the PVC. It may be absent or can be hidden in the QRS or T wave or in front of the QRS. If the P wave follows the QRS, the shape of the P wave may be different. PR interval. If the P wave is in front of the QRS, the PR interval is less than 0.12 seconds. P is to QRS ratio, it can be 0:1 or it can be 1:1. The patient may feel nothing or may say that the heart skipped a beat. The effect of a PVC depends on its timing in the cardiac cycle and how much blood was in the ventricle when they contracted. Initial treatment is aimed at correcting the cause. Medical management. PVCs usually are not serious. PVCs are not considered a warning for ensuing VT, that is ventricular tachycardia. However, a recent study reported a higher frequency of PVCs preceded the development of cardiomyopathy, with an increased incidence of heart failure and increased mortality. Antiarrhythmic drugs is given to the patient. These agents alter the electrophysiologic mechanism responsible for PVCs. PVCs that are frequent and persistent may be treated with amiodarone or sotalol. But long-term pharmacotherapy for only PVC is not usually indicated. In patients with an acute MI, studies have found that PVCs are not associated with sudden cardiac death and do not warrant more aggressive therapy. Beta blockers may be given to the patient. It do not directly affect or reduce the occurrence of PVCs but reduce cardiac contractility, which makes PVCs less obvious to a person. Possibly reduce catecholamine-induced PVCs in catecholamine-sensitive people due to adrenaline not reaching sinus node as much. Calcium channel blockers also can be given. Next treatment is electrolyte replacement. Magnesium supplements, for example, magnesium citrate, orotate, Malox, etc. are given. Potassium supplements, for example, chloride, potassium with citrate ion. Radiofrequency catheter ablation treatment is given to the patient. It is advised for people with ventricular dysfunction and or tachyarrhythmia or very frequent PVC. This procedure is a way to destroy the area of the heart tissue that is caused the irregular contractions characteristics of PVCs using radiofrequency energy. Next treatment is an implantable cardioverter defibrillator or an automated implantable cardioverter defibrillator. It is a device implantable inside our body, is able to perform defibrillation depending on the type, cardioversion and pacing of the heart. This device sends a strong reset signal to our heart when the bottom chambers of our heart are beating very fast or erratically. The ICD is the first-line treatment and prophylactic therapy for patients at risk for sudden cardiac death due to ventricular fibrillation and ventricular tachycardia. Lifestyle modification is also important for the patient. Frequent stressed individuals should consider therapy or join a support group. Let us see ventricular tachycardia. Ventricular tachycardia is a cardiovascular disorder in which fast heart rate occurs in the ventricles of the heart. Ventricular tachycardia is a type of arrhythmia or irregular heart rhythm, sometimes called VT or VTEC. Is an unusually fast heartbeat that starts in the lower part of the heart, called the ventricles. Ventricular tachycardia is a heart rate higher than 120 beats per minute that starts in the heart's two lower chambers, that is ventricles, rather than from the normal electrical pathway. Usually it starts in the SNR, but in this condition it starts in the ventricle. A normal resting heart rate is 60 to 100 beats per minute, but in this case, it will be more than 120 beats per minute. In VT, abnormal electrical signals from ventricles take over and make the heart beat quickly. The pulse coming from SNR are also affected. When this happens, the heart's upper chambers don't have time to refill and send that blood to the ventricles. So, blood doesn't get pumped throughout the body the way it should get. Although a few seconds of VT may not result in permanent problems, longer periods are dangerous and multiple episodes over a short period of time are referred to as an electrical storm. Short periods may occur without symptoms or present with lightheadedness, palpitations, shortness of breath, chest pain and decreased level of consciousness. Ventricular tachycardia may lead to coma and persistent vegetative state due to lack of blood and oxygen to the brain. Ventricular tachycardia may result in ventricular fibrillation and turn into cardiac arrest. This conversion of the VT into VF is called the degeneration of the VT. It is found initially in about 7% of people in cardiac arrest. During an episode of ventricular tachycardia, the heart is beating so fast that blood pressure drops. Heart can't pump enough blood to every part of our body. It starts to have symptoms. Types of ventricular tachycardia. Here are some common terms used to describe ventricular tachycardia. Ventricular tachycardia can be classified based on its morphology. Monomorphic ventricular tachycardia. Monomorphic ventricular tachycardia describes how the heart rhythm looks more steady from beat to beat when doctor checks the electrical activity with an electrocardiogram. Mono means each heartbeat wave looks the same on the machine. Polymorphic ventricular tachycardia. This type of VT is a very dangerous type of arrhythmia. The poly means the heart's electrical activity is all over the place. Person may need a different type of medication or treatment depending on the type of polymorphic VT the person have. Another way to classify ventricular tachycardia is the duration of the episode. Non-sustained ventricular tachycardia. Non-sustained ventricular tachycardia refers to when VT lasts less than 30 seconds. These episodes may come and go, which can make it harder to diagnose at the doctor's office. Sustained ventricular tachycardia. Sustained ventricular tachycardia is when a person have a VT episode for 30 seconds or longer, or it causes a problem like a sudden drop in blood pressure that needs treatment. A third way to classify ventricular tachycardia is on the basis of its symptoms. Pulseless ventricular tachycardia. This type of VT means the ventricles beat so fast they can't fill the blood to send to the rest of the body. They won't have a pulse if the heart can't sustain normal blood flow. This can happen whether they have monomorphic VT or polymorphic VT. Less common is ventricular tachycardia that occurs in individuals with structurally normal hearts. This is known as idiopathic ventricular tachycardia, and in the monomorphic form coincides with little or no increased risk of sudden cardiac death. In general, idiopathic ventricular tachycardia occurs in younger individuals diagnosed with VT. While the causes of idiopathic VT are not known, in general it is presumed to be congenital and can be brought on by any number of diverse factors. Next is pathophysiology. The morphology of the tachycardia depends on its cause and the origin of the re-entry electrical circuit of the heart. In monomorphic ventricular tachycardia, the shape of each heartbeat on the ECG looks the same because the impulse is either being generated from increased automaticity of a single point in either the left or the right ventricle or due to a re-entry circuit within the ventricles. The most common cause of monomorphic ventricular tachycardia is scarring of the heart muscle from a previous myocardial infarction. This scar cannot conduct electrical activity, so there is a potential circuit around the scar that results in the tachycardia. This is similar to the re-entrant circuits that are the cause of atrial flutter and the re-entrant forms of supraventricular tachycardia. Other rarer congenital causes of monomorphic VT include right ventricular dysplasia and right and left ventricular outflow tract VT. Polymorphic ventricular tachycardia, on the other hand, is most commonly caused by abnormalities of ventricular muscle repolarization. The predisposition of this problem usually manifests on the ECG as a prolongation of the QT interval. QT prolongation may be congenital or acute. Congenital problems include long QT syndrome and catecholaminergic polymorphic ventricular tachycardia. Acute problems are usually related to drug toxicity or electrolyte abnormalities, but can occur as a result of myocardial ischemia. Class 3 antiarrhythmic drugs such as sotalol and amiodarone prolong the QT interval and may in some circumstances be proarrhythmic. Other relatively common drugs, including some antibiotics and antihistamines, may also be a danger, in particular in combination with one another. Problems with blood levels of potassium, magnesium, and calcium may also contribute. High-dose magnesium is often used as an antidote in cardiac arrest protocols, also can cause ventricular tachycardia. The characteristics of ventricular tachycardia. Ventricular rate is 100 to 200 beats per minute. Atrial rate depends on the underlying rhythm. Ventricular and atrial rhythm may be regular. QRS duration is 0.12 seconds or it can be more. The shape will be bizarre or abnormal shapes. Very difficult to detect the P wave, so the atrial rate and rhythm may be indeterminable. PR interval will be irregular if P waves are seen. P is to QRS ratio is difficult to determine, but if P waves are apparent, there are usually more QRS complexes than P waves. The patient's tolerance or lack of tolerance for this rapid rhythm depends on the ventricular rate and the severity of ventricular dysfunction. The causes of ventricular tachycardia. VT is defined as 3 or more PVCs in a row occurring at a rate exceeding 100 beats per minute. 3 or more beats in a row on an ECG that originates from the ventricle at a rate of more than 120 beats per minute constitute a ventricular tachycardia. Patients with larger MIs and lower ejection fractions are at higher risk of lethal VT. VT is an emergency because the patient is nearly always unresponsive and pulseless. Ventricular tachycardia is caused by faulty heart signaling that makes the heartbeat too fast in the lower heart chambers called the ventricles. The fast heart rate doesn't allow the ventricles to fill and skews to pump enough blood to the body. Many things can cause or lead to problems with heart signaling and trigger ventricular tachycardia. These include prior heart attack, any heart condition that caused scarring of heart tissue or changes the shape of the heart called structural heart diseases, poor blood flow to the heart muscle due to coronary artery disease, heart problems present at birth including long QT syndrome, changes in levels of body minerals called electrolyte imbalances. These include potassium, sodium, calcium and magnesium. Side effects of some medication can also cause VT. Use of stimulants such as cocaine or methamphetamine, cardiomyopathy, congenital heart conditions, heart failure, heart inflammation, heart surgery, heart valve diseases. Sometimes the exact cause of ventricular tachycardia can be determined. This is called idiopathic ventricular tachycardia. The symptoms of ventricular arrhythmia depend on the type of arrhythmia. Some have no symptoms, especially non-sustained and benign arrhythmias. When the heart beats too fast, it may not send enough blood to the rest of the body, so the organs and tissues may not get enough oxygen. Symptoms of ventricular tachycardia are due to a lack of oxygen. While a few seconds may not result in problems, longer periods are dangerous. Short periods may occur without symptoms or present with lightheadedness, palpitations, shortness of breath, chest pain, unconsciousness. Ventricular tachycardia may turn into ventricular fibrillation and can result in cardiac arrest. Symptoms of sustained ventricular tachycardia may include chest pain called angina, dizziness, feeling lightheadedness or fainting, shortness of breath or trouble breathing, pounding heartbeat that is called palpitations, loss of consciousness, cardiac arrest or sudden death. Ventricular tachycardia can be a medical emergency even if symptoms are very minor. The diagnosis of ventricular tachycardia is made based on the rhythm seen on either a 12-lead ECG or a telemetry rhythm strip. Management of ventricular tachycardia. Several factors determine the initial treatment, identifying the rhythm as monomorphic or polymorphic, determining the existence of a prolonged QT interval before the initiation of VT. Any comorbidities, that is, existence of more than one disease or condition within the body at the same time. Finding out the patient's heart function, whether it is normal or decreased. Therapy may be directed either at terminating an episode of the abnormal heart rhythm or at reducing the risk of another VT episode. The treatment for stable VT is tailored to the specific person with regard to how well the individual tolerates episodes of ventricular tachycardia, how frequently episodes occur, their comorbidities, and their wishes. If the patient is stable, continuing the assessment, especially obtaining a 12-lead ECG, may be the only action necessary to do. Individuals with pulseless VT or unstable VT are hemodynamically compromised and require immediate electric cardioversion to shock them out of the VT rhythm. In those who have normal blood pressure and strong pulse, the antiarrhythmic medication procainamide may be used. Otherwise, immediate cardioversion is recommended, preferably with a biphasic DC shock of 200 joules. In those in cardiac arrest due to ventricular tachycardia, cardiopulmonary resuscitation and defibrillation is recommended. Biphasic defibrillation may be better than monophasic. While waiting for a defibrillator, a precordial thumb may be attempted by those who have experience. To the person in those on a heart monitor who are seen going into an unstable ventricular tachycardia. However, the patient may need antiarrhythmic medications, anti-tachycardia pacing or direct cardioversion or defibrillation. Medications to control the heart rate. These include antiarrhythmic medications such as amiodarone, flecainide, lidocaine, propofenol, or sotalol. For those who are stable with monomorphic waveform, the medication procainamide or sotalol may be used and are better than lidocaine. Evidence does not show that amiodarone is better than procainamide. Procainamide may be used for monomorphic stable VT in patients who do not have acute MI or severe heart failure. IV amiodarone is a medication of choice for a patient with impaired cardiac function or acute MI. Those with an ejection fraction greater than 35% may be managed with amiodarone. Although lidocaine had been the medication most commonly used for immediate short-term therapy, especially for patients with impaired cardiac function, it has no proven short or long-term efficacy in cardiac arrest. Beta blockers that block chemicals is given to the patient that speed up heart. These don't work as well as cardioversion and they can have side effects. Because low magnesium level in the blood is a common cause of VT, magnesium sulfate can be given for torsades de pointes or if a low blood magnesium level is found or suspected. Long-term antiarrhythmic therapy may be indicated to prevent recurrence of VT. Beta blockers and a number of class 3 antiarrhythmics are commonly used. Beta blockers such as carvedilol, metoprolol, and bisoprolol, and the potassium channel blockers like amiodarone, donatorol, bretylium, sotalol, ibutylide, and dofetilide. Angiotensin converting enzyme inhibitors and aldosterone antagonists are also sometimes used. Cardioversion is the treatment of choice for monophasic VT in a symptomatic patient. Defibrillation is the treatment of choice for pulseless VT. Any type of VT in a patient who is unconscious and without a pulse is treated in the same manner as ventricular fibrillation. Immediate defibrillation is the action of choice. For long-term management, patients with an ejection fraction less than 35% should be considered for an implantable cardioverter defibrillator. An implantable cardiac defibrillator or medications such as calcium channel blockage or amiodarone may be used to prevent recurrence. A small percentage of patients with VT have structurally normal hearts and respond well to medications and catheter ablation, and they have an excellent prognosis. If the ventricular rate is above 200 beats per minute, then the presence of an accessory pathway should be suspected. If the ventricular rhythm is irregular, atrial fibrillation should be suspected and treated appropriately. Invasive treatments such as cardiac resynchronization therapy, ICD, cardiac ablation, and open heart surgery are the treatment of choice. In cardiac resynchronization therapy, a small pacemaker implants near collarbone that regulates the electrical signals in ventricles. An implantable cardioverter defibrillator or ICD is a small device placed under the skin just below collarbone. Patient may get it along with a CRT. An ICD delivers a shock to reset heartbeat if it becomes uneven. It is the most effective way to prevent life-threatening problems like sudden cardiac death from ventricular tachycardia. An ICD is more effective than drug therapy for prevention of sudden cardiac death due to ventricular tachycardia and ventricular fibrillation. Cardiac ablation is also called catheter or radiofrequency ablation. In this, doctors use heat to destroy unusual heart tissue. This method treats the ventricular tachycardia and can cure it. Catheter ablation is a potentially definitive treatment option for those with recurrent VT. How to prevent ventricular tachycardia? Focus on heart-healthy habits including eat mostly fruits, vegetables, whole grains, unsaturated fats, and lean proteins. Limit foods high in sugar, salt, and saturated fat. Aim for 30 minutes of cardio most days of the week. Lose excess body weight. Be careful with stimulants like caffeine. Find ways to manage stress. Try to get 7 to 9 hours of sleep a night. Drink alcohol in moderation or not at all. Quit smoking. Avoid recreational drugs such as cocaine or methamphetamines. Torsades de pointes is a polymorphic VT preceded by a prolonged QT interval which could be congenital or acquired. Common causes include central nervous system disease, certain medications such as erythromycin, haloperidol, lithium, methadone, etc. low levels of potassium, calcium, or magnesium. Congenital QT prolongation is another cause because this rhythm is likely to cause the patient to deteriorate and become pulseless. Immediate treatment is required and include correction of any electrolyte imbalance such as administration of IV magnesium and with isoproterenol or pacing if associated with bradycardia.